The title of this presentation is Lymphedema and Beyond. How does the physical therapist see your patient? This was originally given on February 3rd, 2017 to the oncology nursing team in the Women's Center at Smilo as part of their weekly meeting. I was invited to give this presentation. The goal was to be more of an overview with less detail, just to give the participants an idea of how physical therapy sees the patients that they refer to us and some of the thought processes that we go through as we evaluate and treat our patients. First objective groups several pieces of information together. We'll spend a fair amount of time looking at lymphedema as well as patient education in regards to risk factors for development and appropriate interventions. The second one will be fairly quick, but it's important to understand that there are certain physiological changes that go on in the lymphatic system that can cause a patient to not respond to treatment the way we hope they would. The third objective, my goal here, is to have clinicians screening, doing very simple screening activities, looking for things like axillary cording and peripheral nerve tightness in follow-up visits, hoping that these things may trigger referrals if they're identified. I believe in most cases they're just not being looked for. I'll break the discussion down into 4 separate areas. The first being lymphedema in the lymphatic system, which we will spend a fair amount of time on to get the basic knowledge and understanding of the lymphatic system. The second one I grouped together on purpose. My feeling is that in order to give appropriate and consistent patient education, we really need to know what the facts are regarding the risk factors and is lymphedema preventable. The third will be fairly obvious, and the goal of the fourth is, as I mentioned earlier, just to let other clinicians know that we do things other than lymphedema with our breast cancer patients in particular, and that even if someone is referred for lymphedema, we will be looking at these other items, as I mentioned earlier, the lymphatic cording, peripheral nerve tightness, tissue fibrosis, etc. So what is lymphedema? Lymphedema is a buildup of fluid in the body because the lymphatic system is compromised in some way. We're going to talk about secondary lymphedema versus primary lymphedema. The situation with secondary lymphedema is you can take an individual that had a perfectly normal lymphatic system that was functioning normally and impair it in some way. In most cases, this is the result of a surgical procedure, but it can also be compounded by or started by radiation therapy, which can cause tissue fibrosis and damage to some of the superficial lymphatics. We are talking about lymphedema versus edema. We're going to talk about different stages of lymphedema, which we'll get to in the next slide. I want to spend a minute here with the blockage theory. The original thought was that if you impair the lymphatic system in some way, the fluid has no place to go and it's blocked. Similar to the picture we see with the multi-car pileup, the cars behind it cannot get past the pileup. This is true initially. The initial insult is a blockage. What we're finding, and this is some of the reasons that patients do not respond to therapy after a while, particularly in the more chronic cases. What's being found is that there are actual histological changes in the lymph vessel. The lymph vessel can get thicker, and this is happening actually before any swelling is measurable or visible or palpable. The exception here may be the bioimpedance method of measuring, which we can talk about later on in the presentation. It's important to note that the lymphatic system has an internal pumping mechanism. There's smooth muscle in the larger vessels that helps to propel lymph fluid. And what happens is these muscles get weak. And it has been shown that folks with lymphedema lose the ability of these muscles to pump as strongly as the non-involved side. The other thing of interest is that people who have a buildup of fluid in the limb for a period of time, this fluid can actually turn to adipose tissue. So all our techniques which are designed to move fluid will not work because we are trying to move adipose tissue and not fluid. The International Society of Lymphedema, or ISL, has a grading or staging system for lymphedema, which we'll go over briefly. Grade 0 essentially means that there's no swelling present, but the lymphatic system has been compromised in some way. So these are individuals who may have had lymph nodes removed, but they do not show any signs of swelling. Grade 1 is when we start to see measurable changes. It's going to be soft and non-pitting and will resolve with elevation. As you get into grade 2, you start to see skin changes or texture changes. So this is where you'll see fibrosis and pitting. And in grade 2 or stage 2, elevation may reduce the swelling a little bit, but it is not going to completely resolve the swelling. When you get into grade 3, you have severe swelling with skin changes. You're actually going to see structural changes in the skin. And this will be non-pitting. So we'll notice that grade 1 was also non-pitting and grade 3 is non-pitting. The difference is in grade 1, you can actually stick your finger into the limb and it will indent. When you pull the finger out, the skin will bounce back immediately. In grade 3, the reason they say it's non-pitting or will not pit is because when you stick your finger into the limb, the tissue is so hard that you cannot even indent the tissue. Let's talk about the structure and function of the lymphatic system. And here we are going to be talking about the peripheral lymphatic system, which is the part that's going to be involved with surgery and radiation and will be part of our focus clinically. Essentially, we're looking at a return system. The goal of the lymphatic system is to return to the heart anything that the venous system cannot return to the heart. The fluid that gets picked up into the lymphatic system is going to be filtered through the lymph nodes, and this is one of the reasons that physicians need to identify any lymph node that may have cancer in it, because as part of the job of the node is to filter out and try to destroy the cancer cells, they often become overwhelmed by the cancer and can become involved. The endpoint of the venous system is the subclavian vein before it returns to the heart. I'm going to look at several pictures in the next couple of slides and go over some of this again. In particular, the interaction in the interstitial space. This slide has 3 pictures in it. I'm going to look at the one in the upper left to start with. And this is a picture of an initial capillary of the lymphatic system. So this is the smallest structure of the lymphatic system. The capillaries are 1 cell thick. What I've added to the picture is down the bottom of the picture where it says anchoring filaments. The anchoring filaments are attached to skin and surrounding soft tissue, and when the skin is moved, that pulls on the anchoring filament, which opens the initial capillary and gets the fluid into the lymphatic system. We'll look more about the rest of the lymphatic system in just a second. When the person moves or exercises, or when we do a hands-on technique called manual lymph drainage, what we're essentially doing is we're trying to pull on those anchoring filaments to open the initial capillary to get the fluid into the lymphatic system. The goal of the bottom picture, bottom left, is to show the differences in size, or the change in size, of the lymphatic system, starting with the initial capillary, getting into the pre-collectors and collectors, where you will then start to see smooth muscle as well as valves. The smooth muscle to propel the lymph and the valves to prevent backflow. This fluid then is directed to the nodes where it is filtered, and again on back to the subclavian vein that we mentioned earlier. The picture in the upper right is illustrating the capillary bed, if you will, where the fluid is going to come out of the arteriole into the interstitial space. It will then be picked up by the venule, and interspersed here is the initial capillary of the lymphatic system, so whatever fluid is not picked up by the venule, the lymphatic system will pick it up. There's a lot of physics that goes on in here. This is influenced by hydrostatic pressure and oncotic pressure. There is something called Starling's equilibrium that looks at these different pressures and how they all interact with one another, and it's this mathematical formula, if you will, that influences the flow of fluid in and around the capillary beds. So this slide has two pictures. The one on the left is there to illustrate that the lymphatic system essentially covers every square inch of the body, and also to illustrate the direction of the flow towards the lymph node beds. You can see above the waist, the lines that you see are heading towards the left axilla, and below the umbilicus, they're heading down towards the groin. This is something that we need to keep in mind when we're doing our manual lymph drainage, as we're going to try to direct the flow in the direction of the node beds. The picture on the right illustrates the lymph nodes that are involved when the surgeon has to do an axillary lymph node dissection. This is a photograph of a poster we have in our clinic that we use for patient education to illustrate something called a watershed. And the best example of a watershed is a mountaintop, actually, and if it rains on the mountaintop and the rain falls on one side of the peak, it's going to go in one direction, and if it falls on the other side of the peak, it's going to go in another direction. The body is similar. In this poster, you can see some of the brown lines, for example, in the midline of the back, or midline of the front of the body, or at the level of the umbilicus. So if the fluid is to the left of that midline, it will be directed towards the left axilla, in particular if it's above the umbilicus. If it's on the left side and below the umbilicus, it's going to be directed down towards the groin. Same thing across the back. Even if the fluid is on the back, on the left side, it's going to be going towards the left axilla. The green part of the poster shows what we call collateral pathways, and this is something that we use if, for example, the lymph nodes were removed on the left side. We might want to try to reroute this fluid over to the right armpit or the lymph nodes in the right axilla, and we would use these collateral pathways to try to direct the fluid across the body to where we want it, in this case the right axilla. So the slides we just went over were to appreciate the structure and function of the lymphatic system, as well as some of the information that therapists need to know when they are proposing a treatment plan for someone with lymphedema. I want to talk in the next three slides a little bit about numbers, and for example, what is the incidence of people getting upper extremity lymphedema when they've had a lymph node dissection. This is very, very hard to get agreement because it depends on how it's measured, how is lymphedema defined, and what's the length of time of the study. I can tell you that in general, 80 to 90% of people that will get lymphedema from breast cancer surgery are going to get it within the first 18 months to 3 years. Now, that doesn't mean you're out of the woods if you don't get it in that time period. It's just that the rate of people that will get lymphedema are going to get it at a much slower rate. There are documented cases of people getting it even 20 years or more after surgery. It's just that the rate of onset is much slower. In general, if you've had a sentinel lymph node dissection or a sentinel lymph node biopsy, we can expect anywhere from 0 to 3% of those individuals are going to get lymphedema. If you've had an axillary lymph node dissection, that rate is going to be somewhere around 27 to 30%. Very briefly, just an explanation of the sentinel lymph node biopsy and the axillary lymph node dissection. The sentinel lymph node biopsy is something that surgeons do to try to minimize taking a large number of lymph nodes. So they will inject the breast in and around the tumor area with a radioactive substance, and they will trace that and take out the first couple of lymph nodes that pick up this radio tracer. These are removed and sent to the lab for a frozen section. If they come back positive, the surgeon will continue to take more lymph nodes in the axilla. If the surgeon takes lymph nodes from the axilla, the patient is considered to have had an axillary lymph node dissection. If the frozen section comes back that the nodes are negative, the surgeon stops and takes no further lymph nodes, and this we call a sentinel lymph node biopsy. The incidence of lymphedema has changed over the past 50 years or more. Where initially back in the 40s and 50s, if you had an axillary lymph node dissection, about 62% of those individuals who have had an axillary lymph node dissection were going to get lymphedema. 50 years later, that number dropped down to about 25% and really hasn't changed much since. One of the reasons for the reduction is that the surgeons are using less and less invasive procedures, and the fact that lymphedema is now identified as an issue and there is more and earlier intervention for it. Whereas in the past, it was assumed that there was nothing that anyone could do about lymphedema, and there was very little, if any, intervention for it. Now, much to the dismay of women who have had gynecological cancers, the subject of lymphedema for breast cancer patients is much more well studied and looked at and discussed. The problem of lower extremity lymphedema for individuals who've had surgery for gynecological cancers has not been that well studied. We do know that the range may be somewhere in the range of 10 to 30%, but unfortunately there's more undiagnosed leg lymphedema than there is diagnosed lymphedema. We do know that there's a risk of developing lymphedema if you've had 10 or more pelvic lymph nodes removed, as well as if you've had radiation and if you have a high body mass index. Contrary to what we were talking about of the onset of arm lymphedema for the breast cancer patients, most lymphedema, if it's going to develop in these clients, is going to develop in the first year. 3 of the more common gynecological cancers are ovarian, uterine, and vulvar. And most agree that if you've had vulvar cancer, you have a higher chance of getting lymphedema than if you've had ovarian or uterine. There are different measurement techniques for lymphedema. There's several. The picture on the left is water displacement which everyone is familiar with. This is considered the gold standard, if you will, and all other measurement techniques are measured against this. You can use a tape measure, and you can just measure straight circumference differences between the limbs, or you can take sequential measurements and convert them to volume. At this point, we don't know the best interval to measure, whether it's 4 centimeters or 10 centimeters. There are studies that look at less than every 10 centimeters, and we are trying to sort that out as we speak. The third picture from the right is the perometer. This is an infrared scanner. This is very accurate. You can get side-to-side comparisons. You can track volume changes over time. It's a fairly quick measurement technique as well. The picture on the right is called bioimpedance. What this does is it measures electrical resistance in the subcutaneous tissue. You put electrodes on, the machine sends current from one electrode to the other. The theory is that the more fluid there is in the subcutaneous tissue, the more resistance, and the higher the reading in ohms. One of the advantages of the bioimpedance is that you can pick up changes in electrical resistance before you can see or feel or measure changes in limb volume. The disadvantage is that the pads cost about $55 per test. So the next question is, why do some people get lymphedema and some do not? In order to appreciate that question, we must understand the next 2 slides for a framework for the discussion. 2 key concepts are transport capacity and lymphatic load. Transport capacity is the amount of fluid that the lymphatic system is capable of handling. The load is the demand on the system at any given time. To me, a good analogy is your car. The capacity is how fast your car can go. That would be without speed limits and pulled over by the police. And the load is what you need to do at any given time, let's say to get to work. So the car's capacity might be able to go 120 miles an hour, 130 miles an hour, but the load is, it's good enough to go 65 or 75 miles per hour to get to work. The good news is that transport capacity is generally 10 times greater than the lymphatic load. So you can have an impairment of your lymphatic system. In other words, you could have lymph nodes taken out and still have enough capacity to meet the demands of the system or the load, and therefore you will not, or the patient will not, experience any swelling. So let's look at what can cause reduced transport capacity. You could have a reduced number of lymph nodes. In other words, you could have an axillary lymph node dissection where someone has removed the lymph nodes from your body. You can have fibrotic tissue, and this could be within the lymph vessel itself, which we talked about in one of the earlier slides, or it could be the tissue external to the lymph vessel, which is common with radiation-induced fibrosis. Lymph fluid generally does not like to pass scar tissue. You can generally see a buildup of fluid on one side of the incision where the opposite side of the incision has no swelling. We talked about reduced lymphatic pumping. Those smooth muscle pumps within the larger lymph vessels can get weak and not do their job as effectively as they should. The next one, which is converts to adipose tissue, really doesn't fit, in my opinion, under transport capacity or bigger lymphatic load, but it is an issue. It's an actual change in the physiology of the interstitial fluid. And what happens is all the normal techniques that we do for lymphedema do not work. We don't see the reduction in the limb volume that we hope to. Switching gears to bigger lymphatic load, there's a number of issues listed here that can cause the body to have more fluid to deal with and to return to the heart than is normal. We'll talk about some of the chemotherapy medications in a short period of time. Now, and look at a combination of issues. Number one being, what are some of the risk factors for people developing lymphedema, as well as what some of the common patient education that we should or should not be giving our patients regarding lymphedema, and risk factors for developing it, and can they or can they not prevent it. The next three slides look at risk factors for developing lymphedema, divided into three categories. We can go quickly through them. The first being treatment-related, and this being either surgical or other medical interventions that the patient may have. And this is for slide number 20, which is risk factors and disease-related. The next slide looks at the nature of the disease, and based on the nature of the disease, that will dictate what intervention is needed to take care of the problem. So depending on the factors that we see in the slide, that will dictate what surgical intervention is needed, whether they will need chemotherapy or radiation. This is for slide number 21, Roland, which is patient-related risk factors. And the third is patient-related, and that is based on the characteristics of the patient as well as their lifestyle. So this slide is essentially a cluster of risk factors combined from the prior three slides. This is important if we're looking at the concept of surveillance, which means monitoring someone over time a little bit more closely than someone else to see if they're developing lymphedema, and if they do develop it, getting early intervention. Patients with this cluster also would be appropriate for preoperative assessment and preoperative baseline measurements. So for the breast cancer patients, Taxol is known to cause what's called capillary leakage. Obviously, the next one is axillary lymph node dissection, so the more lymph nodes taken out, the higher the risk, as well as the number of positive lymph nodes has bearing here. The more positive lymph nodes, the higher risk for lymphedema. Having a body mass index of 30 or more at time of diagnosis is a risk factor, and radiation therapy, either having received it or planned on receiving it, is a risk factor. When we look at patients who've had treatment for gynecological cancers, again, having the high body mass index, having a pelvic lymph node dissection, as well as radiation puts people at risk. And of the different types of surgeries and different types of gynecological cancers, having vulvar cancer puts you at higher risk for developing lymphedema than does ovarian or cervical cancer. So let's look at the education that we give our patients in regards to the concept of lymphedema prevention. Over the next few slides, we will talk about some of the common precautions patients are told about or hear about, and if they are in fact risk factors for lymphedema development. We will also look at any patient-related issues and if they can or cannot have an impact on lymphedema development. These are several very good review articles on this subject that compile prior research and also look at the strength of the studies on which the advice we are giving patients is based. So what I've done in the next slide is more or less combined everything from those articles and from a multitude of slides I've had on each of these issues individually and tried to put it all into one slide just to summarize everything. So we'll spend a little bit of time on this slide. And let's start with what do we have proof about? And again, what are we giving our patients education about, and is it based on proof? So we do know from very good studies that having the BMI, body mass index, near or above 30 puts the person at risk for developing lymphedema. We know that exercise is not a risk for developing lymphedema and in fact will help it. The common rule for beginning any type of exercise, especially weight training, is start low and go slowly. So progressing perhaps at 10 to 15% at a time is appropriate. I tell people to avoid what I call the gym rat myths, and those are no pain, no gain, and feel the burn. I tell people that those will get them into trouble, and if they go with the prior advice of starting low and going slow, they are perfectly safe exercising, will not risk getting lymphedema, and in fact, if they have lymphedema, the exercise will help. If we move to the right-hand column, which says little or no proof, we can look again at some things that are commonly told to patients. For example, avoid blood pressure, blood draws, and needle sticks in the involved arm. So there's very good evidence in the hand therapy literature that looks at doing carpal tunnel surgery on patients who have lymphedema. Now let's think about a carpal tunnel surgery. That's going to include a tourniquet and a very significant incision around the wrist. The studies show clearly that having carpal tunnel surgery does not increase lymphedema in those patients. The evidence is also very weak on whether having a needle stick will develop lymphedema. My advice for patients is, why risk it? Don't go looking for trouble. If you can have these procedures done in the non-involved arm, by all means do so. If for some reason you happen to have, by mistake, a blood pressure or blood draw done on that arm, try not to get overly concerned about it. I would say that if the patient's having an infusion, that should absolutely be done in the opposite arm or the non-involved arm, infusion being much different than a blood draw or a needle stick / injection. Another common piece of advice we give to patients is to avoid heat. The theory there is that if you heat the area, you're going to increase the blood flow to an area, and the person has an impairment of the lymphatic system and therefore has trouble getting the increased circulation out of that area, and they theorize that will cause lymphedema. With patients with stage or grade 2 lymphedema or above, heat is actually very helpful, according to some very good studies out of China, which looked at heating the arm and immediately bandaging it. And that combination actually gave patients a good reduction in their lymphedema. The next one, I think, is the biggest area of controversy, whether you should or shouldn't fly, and whether you do fly, you should use a compression sleeve when you fly. There seems to be a cutoff of about 5 hours. So domestic flights generally are not going to cause an issue. Longer flights or international flights that go for a longer period of time, there may be a slightly higher chance of developing lymphedema, or if you have lymphedema, making it worse. The question is whether you use a compression sleeve or not, and will that prevent it from happening, is not very clear at all. In fact, in some studies, it appears that the group that wore the sleeve was at a slightly higher risk of developing lymphedema than the group that did not wear the sleeve. Now here's where it gets confusing for patient education. On the other hand, the best thing you can do for someone at the first sign of lymphedema is to get them into a compression sleeve and glove. If you can wear the compression sleeve and glove daily for about 4 weeks, generally at the end of that time period, the lymphedema will go away. The other issue here is, are you at high risk for developing lymphedema or not? So if you're at high risk for developing lymphedema, you could get lymphedema in your arm walking down the street, let alone flying. In that case, I recommend patients have a compression sleeve and glove with them in case they do develop lymphedema. I tell them not to wear it during the flight, but to have it in case it's needed. So I'd like to spend a good amount of time on this subject, as patients do get conflicting information. We've had issues here where one clinic will give one set of instructions and the patient hears different instructions from another clinic. So you can appreciate that this can justifiably cause some patient anxiety. So we're going to leave patient education and move on to the next topic, which is treatment. The standard of care for the treatment of lymphedema is something called complete decongestive therapy. This is broken down into an intensive phase and a maintenance phase. And the intensive phase can be anywhere from 1 to 3 weeks, depending on the patient's needs, and can be up to 5 times a week. It includes all the modalities, including manual lymph drainage, exercise, compression bandaging, skin care, teaching patients self-manual lymph drainage, teaching patients and their families how to do bandaging. Once the person gets the maximum amount of reduction of limb volume, they transfer to the maintenance phase, which essentially is the use of a compression sleeve and continued self-care and monitoring of the arm for any changes in swelling. There is good evidence of the effectiveness of complete decongestive therapy. The reality is that we have many variables that we cannot control, and I'm going to talk about some of those on the next slide. There are many factors that dictate our intervention and the frequency that we can see patients, as well as the effectiveness of our intervention. These, in fact, dictate our care more than a protocol-based approach that we talked about in the prior slide. One of the biggest factors we run into is all the way down at the bottom, which is financial. So the person's insurance coverage, their ability to make co-payments, their ability to pay for parking, do they have transportation or not, and does their insurance cover compression products or not, and if so, how often and what type. This information has to be combined with some of the things from above. In other words, what are some of the medical issues that they're having and some of the comorbidities? Do they have cardiac or kidney issues? And where are they in their treatment? Are they having a chemotherapy treatment that causes capillary leakage? Do they have a chemotherapy treatment such as Doxil that causes extreme skin sensitivity and does not allow the patient to tolerate compression products? These are all the factors that need to come together to create a treatment plan that's individualized to the patient. This slide is an algorithm, if you will, that takes a more global and less protocol-based approach that looks at a particular intervention, which would be across the top, and compares it to the grade or stage of the person's lymphedema, which you'll see in the left column. Without getting too bogged down in details, you can see that the intervention will change and should change based on the patient's individual condition. The next few slides look at various types of intervention. The present slide looks at various types of compression. The picture in the upper left is demonstrating someone at the beginning stages of bandaging. The arm is wrapped with stockinette and then wrapped with a cotton foam padding, and then on top of that wrapped with what's called a short stretch bandaging. The bottom left shows something called a Jovi pack, which is a nighttime compression. That's similar to a very, very large cooking mitt.
You want me to save that?
That is custom fit to the patient's arm, and they can wear it at night. The upper right is your standard compression sleeve that goes from the wrist to the axilla. And then the bottom pictures indicate the glove and the gauntlet. What you see in this slide is actually one of my favorite compression products, which is called Circade. It is applied with Velcro, and as such it's fairly easy to put on and take off. You can expand about 10%. In other words, if the patient gains up to 10% of volume, will still accommodate it. And the person can lose about 30% of volume, and this will still accommodate it. So it is more flexible than a standard compression garment. It can be worn day or night. And I would say the negatives to this are probably a little bit bulky and the cost. Let's talk about a couple of other types of compression. Many people will use an ACE wrap and wonder why it does not work. And the reason is that it has too much elasticity. An ACE wrap will expand about 100% compared to the short stretch bandaging that was in the picture a couple of slides ago, which will expand only about 40%. So the ACE wrap has too much elasticity and will not contain the swelling. Tubigrip and Coban are helpful for initial attempts at compression. This material is available in most clinics, and it allows you to assess the patient's tolerance to compression and gauge their response to compression. And we'll talk about pumps in the next couple of slides. When I first started treating lymphedema, it was not uncommon to see patients whose treatment consisted of the use of a pump combined with a compression stocking. This was not effective, and you would often see those patients coming to you that would have significant tissue fibrosis and pitting, and in the legs could even develop weeping and open wounds as a result of limited treatment. What was neglected was the manual lymph drainage to open the lymphatic pathways and to give the fluid a way out of the congested area. Patients also missed out on the positive effects of the bandaging to soften the fibrotic tissue and help propel the lymph fluid proximally. There definitely are advantages to the use of the pump. For example, you can set it up and relax. And once it is set up, there really is no effort on the part of the patient, so they can set it up and read or watch television. We need to be cautious of several things with the use of the pump. One is that if the proximal pathways are not clear, the pump will push the fluid proximally. However, it will have no way to get by the blockage and will increase proximally. The other issue is that the pump tends to push the fluid but leaves the protein in the interstitial space. By leaving the protein in the interstitial space, you actually will increase the osmotic pressure, which will draw fluid to the protein, potentially causing a worsening of the lymphedema. We can go back and use the analogy of the traffic jam again. And if we try to clear the pile by taking a plow and pushing all the cars from behind through the pile, we will end up getting a bigger mess, a bigger pile with the cars spilling over around the pile, and that is analogous to proximal swelling. Unless we clear the proximal blockage or create a new pathway around the proximal blockage, the congested fluid will have no way out and can cause the problems we mentioned earlier. So when are pumps useful? Well, they're good for self-management, particularly if there's no pitting or skin changes. So this means a stage or grade 1 lymphedema, it is best to be done in conjunction with self-manual lymph drainage and the use of compression. And it is best if you avoid higher pressures that can damage the lymphatics and can force fluid up approximately faster than the lymphatic system can clear it. Some of the research behind the use of compression pumps indicates that pumps will give short-term reduction only, not necessarily maintained over time, but can be made more effective combined with manual lymph drainage, compression, and exercise. As well, it appears there's really no difference between a single-chamber pump versus a multi-chambered pump. And there really seems to be no difference with the use of a pump system that involves the trunk and the limb versus a compression system that involves the limb only. This slide shows two of the modalities that we use in the clinic, the one on the left being the PhysioTouch massager and the one on the right being a low-level laser or a cold laser. The PhysioTouch is essentially an electronic suction cup with different size cups that can be accommodating to different body parts, and it essentially lifts the skin, which pulls on the anchoring filaments, which opens those initial capillaries to get the fluid into the lymphatic system. The machine can be adjusted for pressure as well as on and off time. This machine is actually very good on fibrotic tissue. The cold laser has numerous small studies that show effectiveness in the treatment of lymphedema. My experience with it is that it is very beneficial for fibrotic tissue as well as axillary cording, which we'll talk about shortly. And I don't have as much luck with it on non-pitting early stage lymphedema. Two other things that we haven't touched upon in detail are the manual lymph drainage and exercise. There are specific exercises for the lymphatic system, as well as general exercise, even the use of the upper extremity ergometer and weightlifting, all can be effective to propel lymphatic fluid. In some of the earlier slides, we showed the lymphatic system, including the watersheds and the flow patterns of the lymph system. The goal of manual lymph drainage is to move fluid out of the interstitial space where it is stagnating or collecting and move it towards the node beds to eventually get it out of the system back to the heart. So we're going to leave treatment and then go on to, I guess, what I would call other issues, with an emphasis on the breast cancer patient. And we'll look at some of these items on the slide as well as some other issues over the next few slides. This slide illustrates that there are numerous issues other than lymphedema associated with surgery and radiation for the breast cancer patient. I wouldn't get too hung up on the numbers in parentheses. As you can see, there's such a huge range depending on, as we talked about with lymphedema, the length of time that it's studied, how these things are being measured, and so on and so forth. One thing that often gets neglected in working with a patient who's had reconstruction is abdominal weakness. The tram flap, which isn't being done as much, at least here at Yale, took part of the abdominal muscle, the rectus abdominis, and that would cause abdominal weakness. The deep flap tends to take just the adipose tissue out of the abdomen. However, the person ends up with a incision from one side of the abdomen to the other. So just that fact alone can cause abdominal weakness and even some functional loss initially, you'll see patients have difficulties transferring supine to sit, and sometimes even getting in and out of a chair and in and out of a car. The TAH at the end of the first sentence is for total abdominal hysterectomy, and that can go without saying that that would cause abdominal weakness. This is much better with a robotic surgery versus an open procedure. For patients with gynecological cancers and surgery, you can often see obturator nerve issues with resulting weakness, and in most cases this is transient but should be assessed. And other leg issues to consider is it's fairly common to see lymphedema combined with chronic venous insufficiency, and of course, depending on what the person is doing during the day, it is often very hard for them to get their legs elevated. And so having the leg in a dependent position causes issues both for lymphedema as well as any person that has issues combined with chronic venous insufficiency. In the next two slides, we will be going over something that's called axillary web syndrome or axillary cording. The slide after this has more detail on it, but I'm going to leave this slide up just so you can appreciate the pictures here. What happens, it is believed, is after the person has had the removal of lymph nodes, the fluid that's in the lymph vessels has nowhere to go and becomes stagnant and can become fibrotic. That causes it to lose its elasticity and ability to expand and stretch, so that when the person raises their arm, you can see it standing out or popping right out through the skin. This is visible, and in many cases, even when it's not visible, it's palpable. It's most common to see from the axilla down into the upper part of the arm. You can see it into the breast or chest wall, and in more significant cases, you'll see it down into the elbow and sometimes all the way down into the wrist. This is going to be seen mostly after the person's had a full axillary lymph node dissection, but it can be seen in someone who has had just a sentinel lymph node biopsy, although it's not as common. If you see this in someone who has not had a lymph node dissection, that should be considered a red flag. That means there is some type of tumor or space-occupying lesion or pressure on the lymph vessel that's causing that backup. As I mentioned, it's thought to be fibrosis in the lymph vessel. You will see that the person will have pain and limited range of motion. The most limited range of motion is abduction, and that's the best motion to use to assess cording. In some more recent studies, there seems to be a connection between lymphatic cording and the development of lymphedema, although that has not been well studied. You're at higher risk in this case if you have a low body mass index, whereas for everything else we looked at earlier, having a higher body mass index was more of a risk factor. The good news here is that most people will regain their full range of motion and have no pain, and a very large percentage of people will have no visible or palpable cord. The best treatment that I have found for this is to have the patient's arm rested on the table and bring it into a comfortable amount of abduction. At that point, just light manipulation of the cord along the length of the cord from the axilla as far distal as is needed to mobilize the cord, and then progress the patient into abduction and repeat the whole process. I mentioned earlier that the cold laser is very effective with this treatment, and I am starting to use the physio touch as well, with some, so far, pretty good results. Most of us are familiar with doing our upper limb tension tests and assessment if we've done orthopedics and manual therapy. What we do not see, I do not see, is any mention of upper limb tension test, peripheral nerve tightness in the literature for breast cancer patients. I see this a lot in patients who've had axillary lymph node dissections, and can also see with patients who've had radiation directed to the axilla or the supraclavicular area, which in fact are two common areas to have radiated. When I talked to the nursing staff, which was the original audience, I went over this in some detail. Since this audience, I believe, is my physical therapy peers, we don't have to go over this in too much detail. I just want to emphasize that if you are working with patients who've had surgery for breast cancer or treatment for breast cancer, this should absolutely be assessed. Some of the numerous areas that you can get nerve entrapment, some of which we talked about just earlier, and shows pictures of the course of the brachial plexus as it comes under the clavicle, around the pec minor, and into the axilla. I will say, as far as the frequency that I see involvement, it is definitely the median nerve first, followed by the radial, and hardly ever do I see ulnar nerve involvement in the breast cancer population. And here we see the clinical testing for the median nerve tension test on the left and the radial nerve tension test on the right, which I believe most people are quite familiar with. I had this slide in for the nursing audience for two reasons. One is to illustrate that these are some quick clinical tests that they could do in the clinic if they wanted to screen for peripheral nerve tightness, and as well that these can be used for patient education purposes, just to show the patient how to do this test at home. So hopefully I have successfully communicated that lymphedema and the treatment for lymphedema is not as simple as it seems. In addition to lymphedema, our patient should be assessed for the other issues that we talked about. Consider the advantage of preoperative assessment for our high-risk patients, as well as periodic surveillance and education as to the early warning signs of lymphedema or the early signs of lymphedema so that they can identify it and seek early intervention. We also want to base our patient education on fact and not fiction or hearsay. The next two slides were put in to guide the nursing staff to look for these issues at follow-up visits. These can be a good guide for therapists as well. I find that if the diagnosis is for lymphedema and our original focus is lymphedema, sometimes we fail to look for some of our other areas of involvement, and it is possible for them to go unnoticed and thus unattended. Issues to look for at follow-up visits, if we're focusing on the upper extremity, would be swelling, and this swelling could be in the arm, the breast, or the axilla. We want to look for axillary cording or webbing, and we should look from the axilla all the way to the elbow, and in severe cases to the wrist. This can also be noted going from the axilla into the breast or the chest wall as well. We want to look for our peripheral nerve tension tests, reduced range of motion or strength, as well as pain in the breast, the axilla, the arm or chest wall. And don't forget those individuals who have had tram flaps or deep reconstruction to look for abdominal pain, trunk weakness, and loss of function related to that trunk weakness. Issues to look at on our follow-up visits if the focus is for the lower extremity. We want to be assessing for swelling of the legs, abdomen, and groin, looking for weakness as noted, abdomen and legs, and looking for skin issues, particularly any open areas or fibrosis, any areas of dryness, any weeping, and pain, and that pain can be in the abdominal area, the groin, or the leg. Thanks very much for sticking with me through this presentation. I hope that it was beneficial and you got some good information from it. My email is on the prior slide. I would encourage you to email me with any questions you have, or particularly any comments you have about the presentation, or if you need any specific references. And again, I thank you very much for listening.